Welcome, everybody. It's a little bit after 12, so we'll get started as people continue to join us. On behalf of Dr. Kelly Metcalf and myself, we're very excited to have Dr. Stephen Narod talking to us a little bit about cancers other than the breast and ovarian cancer when we're thinking about the types of cancers mutation carriers are at risk of. And just a little overview of Dr. Stephen Narod for some of you who may not have the opportunity to meet or hear from him. He's a Canadian clinician scientist who works in the field of breast and ovarian cancer. He has a Bachelor's of Science in Mathematics and an MD degree from the University of British Columbia. He conducted a clinical fellowship genetics stay at Sick Hospital and a research fellowship in cancer epidemiology at the International Agency for Research in Cancer in Lyon, France. Dr. Narod holds a Tier 1 Canada Research Chair in breast cancer, and he is a professor at the University of Toronto at the Dal Anna School of Public Health. He has been a senior scientist at the Women's College Research Institute, where he has led the familial breast cancer research unit for over 25 years. And Dr. Narod has made a critical role in shaping our knowledge of how to assess breast and ovarian cancer risk and how to reduce cancer mortality, especially among individuals with a BRCA1 or 2 mutation. His current work is to identify means of reducing mortality for breast cancer in women with not only BRCA1 and BRCA2 mutations, but other breast cancer susceptibility genes. He is also working to define the early stages of breast cancer and how breast cancer spreads. So he has also been awarded many prestigious prizes, and he's a member of the Royal Society of Canada, Canadian Academy of Health Sciences, and is a 2012 winner of the Canada Council for the Arts Killam Prize. So, Dr. Narod, thank you for being here today, and we're very excited to hear your presentation. As always, everybody, please add your questions you may have in the question and answer box, and Dr. Metcalf and I will be happy to navigate those at the end of the presentation. So, Dr. Narod, go ahead. And thank you for being here.
Thanks. Can you hear me? Hello?
Yes, we can hear you. It's all great.
Okay, so this is a bit of an informal presentation. It's kind of like notes I've been taking recently to talk a little bit about mutation carriers, particularly. There's more to it than breast and ovarian cancer. Although we generally follow women, there are some risks for men, albeit a lot lower, and we're going to touch on that. And Joanne did say, this is really stuff we put together as a team here at Women's, and before following women with mutations since 1995, which means some of these patients we've actually been following for 27 years. So here we're talking about women, a little bit about men too. We talk usually about breast and ovarian cancer, but what are the other cancers? Can we screen for them? Can we prevent them ideally? And if we find that we have one of them in the context of being a mutation carrier, is there a different kind of treatment that we should be aware of? So yeah, 25 years go by. And I was around in France back in the old days, in the 80s. We found these genes. And 1994, 1995, when I came to Women's College at 95, and it's been 25 years, we've been following women in our registry. You know, they signed up, many of the patients, survivors, they may be here today, and collecting this information was pretty critical to allow us to evaluate risks and means of reducing risk. So this is really a 25-year story, and hope we continue, but hope that these numbers will continue to drop in terms of cancers. I don't know, I'm kind of starting here, which is a bit weird place to start, which interesting. So this is in Japan. This was in the news quite a bit. I don't know if anybody saw it, but this came out in JAMA Oncology this year. We're talking about BRCA1 and 2 carriers that were identified in Japan. Very few of our patients are Japanese, that's not surprising. And they list here all the cancers and the risks for cancers for BRCA1 and BRCA2. And notably, they're really different from ours. I mean, we kind of highlighted it, but the top one, biliary tract, right? Gallbladder and common bile duct, they have a high risk. Then they see increased risk for cervical cancer, endometrial cancer, esophageal cancer, stomach cancer, gastric cancer, liver cancer, lung cancer, lymphoma, pancreatic cancer, prostate, and kidney. This kind of, I think, stirred up the pot a little bit, suggesting that people with one of these mutations may be at risk for these cancers, which were not otherwise thought of as part of the spectrum. But remember, this is a different methodology. They just take people with cancer and measured whether they had a mutation, and it's a different population. And it should be noted that it's well known in hereditary and non-hereditary world that Japanese people do get a lot of upper GI cancer, which includes stomach and esophagus and liver, and that's pretty rare in Canada. So does this mean the gene is telling the story or the Japanese heritage? Yeah, so this is more or less the same data. Biliary tract, we don't see male breast cancer. They saw mutations quite frequently. Ovarian, we see, but also, so they do see esophageal, gastric, liver, etc. So let's go back to where we stand with our patients. Some of them may be listening. So this is, well, we followed 5,300 women for the last up to 20 years, and 4,000 BRCA1s, 1,300 BRCA2s. And this is sort of the story, and this is the kind of slide that I hope you can see it. It's a little busy, but it's really the combined story of our whole endeavor here at Women's College Hospital. So we see the number of cancers. So these are all women with BRCA1 or two mutations divided up. The cancers they got and the ones and how many died of cancer. So you can see if we start at the number on the left, the overwhelming number was breast, ovary. Then there's a bunch of skin cancers. Nobody died. Peritoneal cancers, we had 28, which is a lot. We'll get back to that. Melanoma, we had 28, so far none of them died. Fallopian tube is a form of cancer we get in BRCA1 and 2 of the tube. Thyroid cancers, that's just common in women. Now we get to pancreas. Pancreas is one that we do concern ourselves with. It's not uncommon. It's pretty rare. And you can see there's a pretty high mortality rate. Then we talk about uterus or endometrial cancer, lung, colon, lymphoma, and a host of other cancers. So putting that in mind, we can look at the cancers, or we can look at the deaths from cancers. This is what we're trying to prevent, right? This is where we want to go. So that's what I want to talk about. I want to get these numbers down to 0. Let's just start with pancreas. So pancreas is one that we do concern ourselves with. The good news is it's pretty rare, right? So of all these 1,000 cancers, 10 were pancreas, which is 1%. Or roughly 60 times less frequent than breast cancer. And that's the good news, because there's not a whole lot of other news. When we, pancreatic cancer does arise in the pancreatic duct, which is a gland near the small intestine. In non-carriers, it's at age 71, but it's relatively common, relatively rare, but it's a 4th leading cause of death from cancer in Canada after lung, colon, and breast. So it does have quite a high mortality. Can we do much about that? At this point, okay, so within the what percentage of them are hereditary? Some of the studies have been done show that about 4 to 7% of them might have a gene, which is a significant fraction, but not high. And as I said before, about 1 in 100 people with a BRCA1 or 2 mutation will get it. So which is pretty much the good news. When we think about prevention, we really don't have much in terms of prevention. Otherwise, we'd tell you. Screening has been done in several centers, including Mount Sinai Hospital, pretty much on a research basis, and hasn't really shown too much success. They have defined these, what they look like, early non-malignant lesions of pancreatic cancer, where some proposed might go on to become cancer. But once they're identified, we don't really have a surgical prevention of them. And the great breakthrough of pancreatic cancer is treatment, olaparib. But you see, this came out in 2019. I mean, that's in the New England Journal of Medicine, the most prestigious journal in the world. What they show that for people with pancreatic cancer, given this drug for BRCA1 carriers, they could increase survival from 4 months to 7 months, which is certainly not nothing, but it's not very dramatic, and it's not where we would like to be. As one would, I mean, generally the medical oncologists and these journals vastly overrate the value of these new therapies. I'm not sure why it is, but I mean, it's a therapy that's available in Ontario for patients with BRCA1 mutations and pancreatic cancer. But it certainly is not going to take us where we want to be. So I guess the message I like to leave about pancreatic cancer, which I wish I had a better one, was let's be grateful that it's rare. So let's just we're going to talk a bit about screening today. So what's a good screening program? We want it to be inexpensive, at least as much as possible. But here we talk about going for the high-risk people. It could be a little more expensive. We want it to be easy to administer, accessible to all the women who might be at risk, reliable, valid. We don't want to give 100 people a positive test to identify one cancer. We don't want to put 100 people through surgery to identify one cancer. We'd like it to be pretty specific. So if you don't have cancer, the test is negative, and we like it to be pretty sensitive. So if you do have cancer, the test is positive. And it should be shown to reduce mortality. So we can talk a bit about prostate cancer. I mean, the jury is actually still out on whether screening for prostate cancer is effective or not in terms of reducing mortality. It's my opinion that it is, but it's not completely clear. So the prostate's a gland surrounding the urethra at the exit of the bladder, becomes enlarged in most men as they grow older and causes some symptoms. And but those symptoms are not usually related to cancer. Cancer is generally found by screening with a blood test called PSA. Now, I wrote a paper years ago before any genes were found. This isn't mine, but mine came out a long time ago, that having a father or brother with prostate cancer was a big risk factor. And it still is. Now we focus on genes like BRCA1 and BRCA2, but I think still having a relative with prostate cancer is a bigger contributor than the genes themselves. So having a brother with prostate cancer increases your risk by 3-fold, which is about the same as the BRCA1 or BRCA2 mutation, but it's way more common. So I think we have to go back and think about what we should be focusing on. Should we still be thinking about family histories as we did back in 2003, or should we limit our attention to doing genetic tests? This is something I'd like to readdress. Because when I look at this, it seems to me, after all these years going by, that a lot of men are at risk of prostate cancer because they have a brother affected or a father affected, even though their genetic test is negative. So in terms of what percentage of men have prostate cancer have a mutation, it's about 4%. But for metastatic prostate cancer, cancer that's already spread, it become really a concern, a threat to mortality. It's about 6%, 6 to 7% had a mutation, which leads us to think that, there are two kind of schools of thought here. One is we should test men with metastatic prostate cancer because they could get some drugs, it's not all that effective. Or we should test men with low-grade prostate cancer, early prostate cancer, with the hope that we could prevent them from progressing to metastatic prostate cancer. Or should we test all men in the general population, hoping to find them and then hoping to prevent cancer in the first place? And it's sort of a testimony to how little progress we've made is that we're still thinking about that question, 25 years later. I was just at a hereditary prostate cancer at the Princess Margaret Hospital where the world experts are got together. And there was still not much of a consensus. And the only thing people really felt comfortable was we should test men with metastatic prostate cancer because the yield is pretty high. Although there's no clear evidence that we can give them a new kind of drug, a tailored therapy that's tailored. But should say BRCA2 is a much bigger contributor than BRCA1. When I see a man with BRCA2 mutation, I do send him up to Sunnybrook with our colleagues up there and make sure they do get regular screening with PSA. Prevention, there have been a bunch of trials, none of them have ever found it, and there's no way to prevent prostate cancer. Screening, we have the PSA test, as I say, I support it. There's various papers saying it works, various papers saying it's not necessary. In terms of treatment for the BRCA2 carrier, I would say surgery, or I would say surgery, do it right away. My recommendation, the only strong recommendation I have here is to avoid active surveillance. Active surveillance is the notion that you can identify a man with prostate cancer and hold off on treating it aggressively, hold off on the surgery, hold off on radiotherapy until we see evidence of that prostate cancer progressing, in which case it intervenes. It's a balance between the chance that the cancer is going to progress and the side effects of the surgery and the radiotherapy. Remember, and this is real important, it's similar to breast cancer, but different than ovarian cancer. Most men that are diagnosed with prostate cancer in Ontario in 2022 have no symptoms. There are some that do. They come with back pain, they come with other things, but the great majority of prostate cancers are, the guy went to the doctor, he ordered a PSA test. The PSA was over 3, they had a biopsy and they had cancer. It's very similar to small breast cancers. Most breast cancers diagnosed in Ontario today don't have symptoms except possibly a small feeling of lump, but most are diagnosed through a screening mammography. Some do have a lump, of course, but very few women, only about 5% of women with breast cancer have symptoms related to the cancer when they present. Contrast that with ovarian cancer, where it's almost 100% of women who are diagnosed with ovarian cancer get the diagnosis because they went to the doctor, said, "Doctor, I got difficulties, etc." They had a test, a blood test or an ultrasound and found it. The prostate and thyroid and breast are the cancers. Most of them are diagnosed through screening asymptomatically, and we have to be cautious that we don't do anything unnecessary or too aggressive that's not necessary. Okay, now let's talk about peritoneal cancer. Peritoneal cancer is the one we wish would go away. Some of you have heard of it, a bunch of you haven't heard of it. It comes from the word peritoneum, which is kind of this lining of the abdominal cavity. It lines the ovaries, the fallopian tube, the uterus, the colon, the liver, the omentum, and all the spleen. So it's sort of the lining, the skin lining that's inside your abdomen, and it's called the peritoneum. And we define as, for me, I define peritoneal cancer as any cancer that arises within the abdominal cavity without a known other site after an oophorectomy. Because if you have your ovaries intact and you're diagnosed with cancer that looks like peritoneal or ovarian, it's very difficult to distinguish. But so these women, these 28 women in my study, were 28 women who had their ovaries removed, preventive, and had no cancer diagnosed at the time. Their ovaries looked fine. And years, 1 or 2 or 3 or 4 years later, they developed peritoneal cancer. So we got 150 ovarian cancers, 28 peritoneal cancers. In terms of deaths, we got 61 deaths from ovarian and 11 from peritoneal. Now, this does look like bad news. In fact, it's strangely, this is progress. And why do I say it's progress? Because if we did what I would like to think we could do and identified everybody with a BRCA1 or BRCA2 mutation before they developed those symptoms that I just mentioned. And those people went to their doctor and the surgeon removed their ovaries and fallopian tubes while they were young enough before any cancer had set in, we would prevent all the ovarian cancers. And the numbers that would then go ovarian cancer 0, peritoneal 28. So the fact, as we progress, this is counterintuitive, but a bit fascinating, letting into our insights. As we progress in time in our fight against hereditary cancer, we will see a much greater increase in the number of peritoneal cancers and a decrease in ovarian cancers. Just because we're good at preventing ovarian cancer surgically, but we have no means at our disposal to prevent peritoneal cancers. Now we have two theories here, and I'm still stuck on which is which, and I've got more data than anybody in the world. So peritoneal cancer is a cancer that we define, and it rises in the abdominal cavity after an ovarectomy, and it looks like metastatic ovarian cancer, and it behaves like metastatic ovarian cancer. You can see the ratio of diagnoses to deaths is very high. The question is it a primary cancer? I mean, did it arise in the abdomen? It's just a new kind of cancer, or was it a spread from an ovarian cancer that nobody saw, nobody appreciated was present at the time the surgery was done? We like to think our preferred interpretation of those two is it's a metastatic spread from an occult fallopian tube cancer rather than a new cancer with its own life. The reason we like that is because if that were to be the case, if the peritoneal cancer was a spread of an unheralded fallopian tube cancer, then we could prevent it by earlier surgery of the fallopian tubes. Now, we recommend BRCA1 carriers get the ovarectomy with the fallopian tubes removed at age 35. And this is one of the reasons. It's actually quite, I'm working on this now, but we see the risk of peritoneal cancer after an ovarectomy to be 2.8% for a BRCA1 carrier and 1.4% for a BRCA2 carrier. Now, this is way lower than the risk of ovarian cancer. So doing the ovarectomy, it's good. These peritoneal cancer numbers are way lower than the risk would be if we left the ovaries intact, but they're way higher than we want them to be. In fact, I mean, look at, on the average woman in Ontario without a mutation, her chance of getting ovarian cancer in her lifetime is about 1%. So even for a BRCA2 carrier without ovaries, her risk is higher than a non-carrier with ovaries. However, the ovarectomy is something we have to do because that's the only way we really can fight against it. Now, what I'm starting to see, the good news is, the risk does look to be lower if the ovarectomy is done before age 35, which is the recommended age, suggesting that maybe some of these, if not all of them, are the spread of cancers in the fallopian tubes that were present but not seen at the time surgery was done. Second thing, which I see, and I don't know what to make of it quite yet, is that the risk is lower for women who had their ovarectomy done recently than if they were done 20 or 30 years ago. Maybe the surgical techniques and the pathology techniques weren't mastered yet. This is something, it's an ongoing story. And it certainly, as we get better and better in preventing ovarian cancer, we got to kind of shift our focus a bit and get better in preventing peritoneal cancer. So we call that STIC. This is going back to what I alluded to in the fallopian tube, which we see sort of enlarged in this cartoon on the left. You see the ovary, I don't know, you can, around here, the fallopian tube. It's believed that these ovarian cancers arise in the fallopian tubes, and then the cancer cells spread to the ovary to become ovarian cancer and spread to the peritoneum to become distant metastases, like peritoneal cancer. And if you find this in, if you get a woman who has preventive surgery, you have to look carefully at the fallopian tubes, And if you see this, what they call serous tubal intraepithelial cancer, that's puts you at high risk of peritoneal cancer. But we're still, there's only been a couple of papers published, but we're trying to look at that very carefully. If this were the case, as I say, then we would be shifting our attention towards removing these tubes earlier on in life to avoid this scenario. Endometrial cancer, there's still a fair bit of controversy about if this really part of BRCA1 or BRCA2. It does seem that there are some rare forms that are part of the BRCA1 and BRCA2 spectrum. Now, I'm an advocate, so that means, so when we talk about, so here we go, nice picture, got everything we want. This is the ovary, two of them paired, the fallopian tube, the fimbria on the end of the fallopian tube, which collect the ovary. Well, these are here to collect eggs, fertilized eggs, and bring them down into the fallopian tube to become implanted in the uterus, and that's where the baby grows. We don't talk much about babies in we talk about cancer, so we think of these things, it's kind of odd. We kind of think of all these things as targets to get cancer, whereas, you know, most of the world thinks of these things as a blessing. This is the apparatus that we're endowed with to be able to reproduce and have children, which we all think is a good thing. But unfortunately, some of these can be bad and lead to cancers. So we're always stuck as doctors. I mean, whether that's a cancer genetics guy like me, a gynecologist or an oncologist, is this balance between fertility, pursuing fertility, preserving the ability to have kids, and the menopause. Once you take out the ovaries, you put the woman in menopause and she gets symptoms, and cancer risk. So we got three things on the table. How you want to have fertility, right? You want to have a baby. Not everybody does, but lots do. We want to prevent all the cancers. I can prevent these cancers. Just I cut from here to here and take it away. And we want to avoid the signs of menopause, the symptoms of menopause, hot flushes, mood swings, etc. And that's why, I mean, this is really a multidisciplinary goal, and we got a lot of people at Women's College Hospital that are thinking about this every day. So you can prevent endometrial cancer, just like prevent ovarian cancer, and just like prevent fallopian cancer. You got to, but we recommend the oophorectomy at age 35. Not everybody recommends a hysterectomy. They say, well, it's a bigger operation, and it's not clear that the endometrial cancer or the uterine cancer is a manifestation of the gene. And with that, I would agree. However, sitting in my seat on the 6th floor here, I say to myself, okay, here's all my women that got cancer. I got 17 uterine cancers. 2 died. Those can be avoided by the surgery. You know, so if I add everything up, I put this line as preventable. Remember pancreas, we didn't get that shot, but this one I can prevent. I'm of the opinion that I want these numbers. My goal is to get this number down to 0. There are other people whose goals might be to, you know, for quality of life, for having babies, for etc. And I don't disagree with those goals. I'm just saying, as I look at it from the numbers, and what I'm showing you today, which is, by the way, the largest numbers in the world that have been followed, I think I would rather that go to 0. Now, you can be sure there are a lot fewer endometrial cancers than ovarian cancers, but if I can prevent them, why not? It's a question of debate. Colon cancer. The Japanese found an increased risk. I wrote 2 papers about this. One, I found an increased risk, and then I didn't find an increased risk. Currently, for women, we do see an increased risk of colon cancer under 50. I have to have another look at that paper. How many were there? I mean, again, we're starting to tread on thin water because, like, in 1,000 women followed for 20 years or something, I got 14 of them. 3 in BRCA1, 13 in BRCA1 and 1 in BRCA2. Now look at that carefully. That's the only one there where the split's so dramatic. If these were a chance, I would see that, you know, like a 3-to-1. I got 3 times more women with a BRCA1 mutation than I do with the BRCA2. Lo and behold, if I look at breast, I got 3 times as many, about that. If I look at skin, there's more BRCA2s. That's true. Everybody knows BRCA2 is bad for skin. Peritoneal, the balance is in favor of the risk is a bit higher. And it's as we go through them, there are these differences can be relevant. The strongest was colon. I got 14 colon cancers. Most of those are young women. Now I'm recommending colonoscopy from, not sure what age, certainly from age 50. We have the opportunity to prevent colon cancer, at least screening for it. There's no, the prevention is, there was a big trial on hereditary colon cancer, but those were people with a different gene. They took aspirin and it worked. Screening, well, we have a pretty good test, FIT test, which is a stool test, and some wish to go right to the colonoscopy. I wouldn't advise against it. Certainly with me personally, when I want to get a screen for colon cancer, I went for colonoscopy because it's pretty definitive. It tells you you don't have colon cancer. We currently, it's not currently in the BRCA1 world, it's not a clean recommendation, a clear recommendation, but I'm going to go back. If I publish this, I think we got a pretty strong case that we should be screening for colon cancer. So that was a fast tour of, okay, what time is it? Oh, good. So after all this 25 years of looking at numbers and following women and telling people what to do, what have I got left? Not that much, but it's nice because I can summarize my entire philosophy of hereditary BRCA1 and 2 for women in one slide, and it's not even like a complicated slide. It's not even a busy slide, it's just a regular slide with a few lines on it. So I think you gotta, for those who have a BRCA1 mutation and the women otherwise healthy, we recommend a oophorectomy with hysterectomy at age 35 for BRCA1, at age 45 for BRCA2. This is done to me because it prevents breast cancer. It prevents ovarian cancer, endometrial cancer, cervical cancer, ovarian cancer, fallopian tube cancer. Not everybody agrees. There are 2 ways you could disagree with me. One, you can suggest not to have the hysterectomy, which is fair enough. I'm just trying to get out those endometrial cancers. The other one, which is leading us to some controversy here and around the world, is can you remove the fallopian tubes and leave the ovaries behind? I showed a slide, maybe we can go back to it, that we believe and not sure that the ovarian cancers arise in the fallopian tubes, and you see those cells, those cancer cells, those culprits coming out of the tube to land on and those can cause the ovarian cancer. If that was absolutely true, we could remove the fallopian tube, leave the ovaries, and prevent the ovarian cancer. It's theoretical. There's no proof of it. I see all these cancers. I see the 61. That's the #1 leading cancer death of BRCA1 carriers, right? More breast cancers, more deaths from ovary. I don't want to take any chances. I'm not prepared to go on based on this diagram to tell the woman it's okay, you can leave your ovaries. But BRCA2, we do see a difference. We see they don't really start till age 45. But I go with the oophorectomy. I go with the hysterectomy because if you want to reduce the number of cancers to the minimum as you can, why not? Okay, so now that's second one. Now the second one, the world has changed. You know, when I started this in 1995, we said, well, we give the women the information and they make the decision based on what they know, the risks and benefits of these. Fair enough, we still do that, but the world has also changed that the oophorectomy is now you'll see the word oophorectomy is recommended. All the guidelines say the same, oophorectomy is recommended. And they say what we recommend discussion of preventive mastectomy. They don't go as far as recommend the preventive mastectomy. They recommend discussion of preventive mastectomy with the patient for good reason. It's not something people like to recommend have your breast removed, but we do think women should be aware of the high risk of breast cancer, like 80%, and the effectiveness of the preventive mastectomy. And some women choose it, but what I can really say is, if you choose not to have it, then I recommend you get an MRI and an oophorectomy. And the data on tamoxifen is emerging. Okay, so I'm happy to if a woman comes to me and says, "Doc, I don't want that preventive breast surgery. What do you suggest?" I says, "I don't suggest. I recommend you go for an oophorectomy for the reasons I've shown. You get your MRI. Fortunately, it's covered every year. It's done here at the Women's College Hospital. We're just working on that data today, and lo and behold, it looks pretty good. Tamoxifen." It's, we do see a reduction in risk around 30 or 40% of breast cancer, which is not trivial, given the high risk is, and we're starting at a risk of 70%, right? You're starting at a real high risk, like 70%. If you can reduce that to like 50% or 40%, is that worth taking tamoxifen? I think so, but there's there's a level of evidence, and there's the side effects to consider. But certainly, no one would recommend tamoxifen as a suitable alternative, a rational alternative to mastectomy, MRI, or oophorectomy. It is something to consider in the context of both. I showed you some stuff on prostate cancer. Mostly it's a concern for BRCA2 men. I think they should get an annual PSA from age 40. It may turn out that I'm wrong. I mean, it may turn out when we get all the data together, which is taking painfully long and slow. And I think I should do something to accelerate that, because I'm getting a little. We should have a much better idea of what the risks are for BRCA2 and how you treat them. I mean, when you treat a guy with prostate cancer, you've got the option of wait and see. You've got the option of radiation, and you've got the option of surgery. And if I say to the surgeons and that which is the best, they say we don't know. Well, time we found that out. Colonoscopy. Data is emerging that's for young women with BRCA1 mutations, it seems to be a risk, not a high risk, but a risk that is not trivial. And we do have something for that, which is FIT tests, screening tests, or colonoscopy. So as of this year, I do think that the evidence is weighing on the side that we should screen for colonoscopy, now for colon cancer. Remember, every time we look at these things, we got to go back to the beginning. Can I prevent it? Can I screen for it, or can I treat it? Now, the amazing thing here, well, I like it. This is it. If you come into the talk now, you're not going to miss anything. These are the number of cancers we got in all these women. And the ones in yellow are the ones we can prevent with surgery, right? I can prevent those 60 breast cancers. I can prevent the ovarian cancers and the fallopian tube and the uterus and the cervix. Mind you, the prevention involves surgery. It's not like I can have a pill and do it. I have to go into the operating room. But of all those 169 cancers that we got, these women got those cancers. They could have been prevented. So, I mean, these are the women that were the forerunners. These are the trailblazers that made the choices of the different options, and the ones that got cancer gave us information that's valuable for the next generation. But as I say, I can prevent those 60 breasts, ovaries, fallopians. I check in the deaths. These are the deaths from, so why not? Now, the blue ones, the peritoneal, the colon, and the lung. Those deaths, I don't know how to prevent, but that's what I think we should be pushing for. We've got to do more research on peritoneal, because that's going to become more and more a problem as we do better in preventing the ovaries. we're going to have more women present with peritoneal cancer, and we got to think on that one. That one's, you see, that one is the third most common cause of death. I got to work on that. Pancreas was 7. It's a number, but we haven't really got a strategy. Thank God it's a 7 and not a 70, but that's where we are. Lung cancer, I could sort of put it in blue. I guess it's preventable, but I mean, the prevention is non-smoking. And it's not clear to me if the women with the BRCA1 and 2 mutations smoked. We have to go look at that. And so I would rather not make that implication unless I had the reason to believe it. Colon cancer, small number of deaths, but I think maybe we should be able to. So I'm got my personal agenda here is to keep working on colon, lung, and peritoneal. Let's see if I can get those numbers down. But we've come, I'd say, a hell of a long way. I mean, looking at the sense of what percentage of the deaths are preventable, it's most of them. I want to get a better way of doing it, though. Surgically is kind of an unhappy alternative, but it's at least we have something that we can start with and we can move forward with. And this has been a kind of a journey, 25 years, me, Kelly, Joanne, Mohammed, they've been working together. You guys are the first ones to see this table, by the way, which I think is kind of neat because it sums up a lot of work and a lot of time. And I think that's it. So I can leave it on or I can take it off, but we can take questions. I don't know if there are any.
Thank you so much, Dr. Narod. That was excellent and exciting to see that new data and thinking about some of the paths that we need to go down in terms of our next research. But we do have some questions from the audience. So I would encourage you all who are on today. I'm sure there were there's some new data here that you may have questions about that you haven't seen before. So please just type in your question and Dr. Kotsopoulos and I can ask Dr. Narod so everyone can hear, because often it's, if you're thinking about a question, many others might have that same question as well. So let's start with the first question, and it's about prostate cancer, Dr. Narod. So do you think that the risk of prostate cancer being higher in a familial connection rather than genetic testing is indicative of limitations of our current way of offering genetic testing? So are we
Yeah, that's a really good question. To tell you the truth, I never, till last week, I was putting this thing together and I asked for people to send me their slides. I got slides. I didn't do any work, of course. I called up Danny and I called up the people, Emily at the PMAs. I said, you got any slides on prostate cancer? Send me your slides. I got to give a talk. And I don't have any time to prepare it. So they sent me the slides and I'm looking at these slides about the family history and realizing the family history is such an important component. How much of that is due to genes? I don't know if we've done the simple study, like take all the men with prostate cancer, do the family history and the mutation, and see if I can find people that are at risk. I mean, you got two, you could have neither, you could have one, or you could have both, right? Are there people with a mutation? And I mean, here's the simplest question I could ask, and I don't know the answer. If I got a BRCA2 mutation and my brother has prostate cancer, am I at higher risk if I have the same mutation and my brother doesn't? You think we'd have figured that one out by now? Also, so we better do that. So we'll have to get back to the prostate business. But those family histories are strong. And there's probably, it's not just that they're strong. There's way more men out there that have a first degree relative with prostate cancer than are that have a BRCA2 mutation, right? So why don't we?
Do we know anything about those prostate cancers? You presented some data today on
I don't know anything about them.
Nature.
I think it's something we should do, though. I don't know hardly anything about them. Kind of freaked me out to read that.
But important for the men in these BRCA2 families to have testing, to be aware whether or not they carry the BRCA2 mutation.
Oh, definitely, yeah.
So for any of you who are on the call and there's a BRCA2 mutation in your family, please encourage the men to be tested and we can help.
And put it another way, of all the genes out there, the one that is most linked to prostate is BRCA2. There's
Yeah.
probably 20 genes which have some connection with prostate cancer. But the big one is in terms of risk and in terms of mortality and treatment is BRCA2. When I see a man with a BRCA2 mutation in prostate cancer, I think they should have surgery right away, and one shouldn't be too deliberating on that role.
Okay, great, thank you.
So our next question is about multiple primaries, which is interesting. And one of our participants has a mother who was diagnosed with primary peritoneal cancer and then later developed second primary of pancreatic cancer. So have we ever taken a look in our cohort at multiple primaries in our individuals? I guess beyond breast and ovarian. So
Yeah, okay, so that's a good question. Do we think that it's kind of tough to do. I mean, I will say that I can say this. In the 25 years I've been working in this business, I never heard of anybody getting both pancreas and peritoneal. Largely because they're both relatively rare and one doesn't generally survive long enough. We see plenty of women get another cancer after breast cancer. I mean, after 10 years after breast cancer, 90% plus of them are alive, and so they can get ovarian cancer. We see a lot, when you're talking about primary peritoneal cancer, the big one is breast, then they get ovarian. That's the one that should all be avoided. Anybody in 2022 who gets ovarian cancer after diagnosis of breast cancer has not been given good treatment. Having said that, peritoneal, I don't have a way to prevent the pancreas or the peritoneal, so those ones are tough. But in terms of real multiple primary cancers, if I could reduce, the number one is breast and ovary, you can get rid of those, that would be the first. Certainly when a person has breast cancer, we would recommend further testing for colon cancer, ovarian cancer, even melanoma. But person with peritoneal cancer, one would not encourage them to get screening. I mean, because of you have to be able to do something about it if you find it. Unfortunate case, but hopefully that's rare.
okay, thank
And an
you.
important point there, Dr. Narod, I think if someone is diagnosed with a cancer, especially breast cancer, we can't stop thinking about the other cancers that they're at risk of. So if you've had a diagnosis of breast cancer, you still need to be thinking about your ovarian cancer risk. So please be talking to your healthcare providers about that.
And the healthcare providers should figure that out themselves. I agree. It does strike me as a bit odd in 2022 that, you know, the women can go to the doctor, be 45 years old and have a triple negative breast cancer, and they don't get tested for I don't know, Kelly, what's are they?
And I know, and we do have cases of women getting ovarian cancer after breast cancer, and that really is a failure because we've identified them with a mutation. So we want to avoid that happening. So please be aware of the ages that these surgeries are being recommended at, especially if you're a BRCA1. 35 is a young age to be thinking about having your ovaries out, but we have the data to support that age of surgery. So please, or come back and visit your genetic counselor if you think that that would be helpful as well.
Before we move on to the next question, I see a lot of attendees lifting their hands in the chat box, but unfortunately that is not enabled. So please post all your questions in the chat box. Thank you.
So here's another interesting question. I think it's something that we've been thinking about, both Joanne and Dr. Mohammed Akbari, about looking at biomarkers to detect early cancer and ovarian cancer. And maybe for those who aren't available or aren't aware of what a biomarker is, first of all, you could give a quick explanation. And is there any evidence about early detection for ovarian cancer using biomarkers?
Sure. I mean, you know, biomarkers, anything you take in the blood that indicates that you have a cancer. It's different from a risk factor. It says if this is high, your chance of having a cancer are higher than normal. That things like CA125 is a biomarker. Platelets are a biomarker. High platelets put you at high, you could have ovarian cancer. CA125, you could have it. It's really strange. Okay, so let's talk about that a bit. In the history, hasn't really been shown clinically by research that screening for ovarian cancer with CA125 is effective to reduce the risk of dying of ovarian cancer. Could be for several reasons. Mostly these things go fast. On the other hand, the average woman who got ovarian, we think of ovarian CM25 above 10 to be suspicious. Above 100, you got ovarian cancer. The average woman who shows up at the emergency ward with ovarian cancer in Ontario has a CM25 of 600. Wasn't it something like 600? It was bizarrely high. So where did we miss it?
1,000. It was very
It was
high.
like 1,000. I mean, the average woman who shows up at the emergency ward had a CA125 of 1,000 and had been to her doctor the past 3 months. So
And
it-
usually is presenting in the emergency room and not.
yeah, what are they doing presenting in the emergency room 6 months after they went to the doctor complaining of abdominal pain? So I don't know. I mean, that's a really tough question. There's tons of people doing it. There's tons of people using that circulating DNA for biomarkers. I mean, we have proteomic biomarkers like CM125. There are people doing research on it. Biomarkers have 3 values. It's considered. One is to diagnose it early. 2, which is really interesting, is to see if you need chemotherapy. There are people that say if you do a surgery on a patient and the surgery got all the cancer and the biomarker shows no evidence of cancer, that person doesn't need chemo. That would be great. And 3rd is to follow to see if that patient recurs. If you can pick up the recurrence early, then you can intervene with treatment. In this world, it's all theoretical. We don't have any biomarkers with the exception of PSA. So PSA is a biomarker for prostate cancer, which I put on my last slide. So I didn't put other ones on. I didn't put go for CM125. I didn't put go. I said go for PSA biomarker. There's tons going on. Mohammed could give an hour lecture for that. Maybe we should, but I'm not the guy.
Okay, thank you. So we actually have a question surrounding ages at oophorectomy, and one of our participants is thanking you for a wonderful presentation, especially the risk of peritoneal cancer after oophorectomy. So we know that NCCN guidelines suggest oophorectomy be performed between ages 35 and 40 for BRCA1 and 40 and 45 for BRCA2. So what about considering oophorectomy prior to age 35 if it's having such a strong effect on primary peritoneal cancer?
Say what?
So has there ever been discussion of oophorectomy prior to age 35, for example?
Yeah, that's a really good question. We don't have that much data. We have done, I mean, I have it, I can't remember, but we've done 1,000 oophorectomies on under 35 and found a few cancers. So we look at that from the point of view, it's you did it. We look at all the oophorectomies that we did in our database by age and what's the chance of finding cancer under 35. There was, I think, 2 or 3 cancers that we found out of a few hundred surgeries, and our conclusion was that there wasn't enough to bump the risk down. And to go before 35 is very like we don't want to go below 35, and I need a damn good reason before I go below it. And that may be that reasons will be one of 2 things. 1, the risk of occult cancer is higher than we thought, and 2, the risk of peritoneal cancer. If I thought you could reduce the risk of peritoneal cancer to 0 by having the oophorectomy earlier than 35, I'd recommend it. But I don't have that yet.
And you're correct. In our study where we looked at all the women who had by age at oophorectomy, we found 1 cancer in a woman who had an oophorectomy before age 35.
Yeah, and so that there is one possible exception. I hope you guys don't have. If the woman has breast cancer, unfortunately some do, before age 35, we do see a benefit of an oophorectomy for the breast cancer beyond that of preventing the ovarian cancer. But that's something to discuss on an individual basis.
Okay, thank you.
Okay, Dr. Narod. So we've talked a little bit about hysterectomies today and the risk of uterine cancer in BRCA1 and BRCA2 carriers. So if someone has had a previous oophorectomy where the ovaries and the fallopian tubes have been removed, and the uterus is, the woman still has her uterus, should she now be thinking about going back to have her uterus removed as a separate surgery?
Yeah, we generally would say no. Now let's go back a bit. If she had her ovaries removed and her fallopian tubes are still there, we pretty much say, yeah, go back and remove your fallopian tubes and uterus. not everybody knows that. It's not like clear to everybody who has a hysterectomy, whether they had their tubes removed. If you have your ovaries and your hysterectomy, you got your tubes removed. But if you had just your ovaries removed, you'll know if you had your uterus removed. You may not know. Anyways, we go back to remove tubes as a risk factor. We wouldn't go back to remove the hysterectomy. The only exception is one, which is, so if you go for your gallbladder or an appendix or something, if they're going to do an abdominal surgery for another reason, and you're under the anesthetic generally you could have the hysterectomy at that time. I don't think there's enough risk to do a hysterectomy on a healthy woman. There are other genes out there, what we call Lynch syndrome, right? Which I'm not the expert on, which have endometrial cancer as a predominant cancer, but we would do hysterectomy for them, but that's other genes, not those genes we test for actually on our panel, which confuses things. But BRCA1 or BRCA2, the answer I think is no.
Okay. All right. Well, thank you so much, Dr. Narod, for presenting very up-to-date data for us to think about today. And you can see how things have changed in terms of recommendations over time, thinking about some of these other cancers that we maybe need to be thinking about. So I want to thank you today for putting this all together for us. Very interesting. And I just want to let everybody know that we will be sending around an evaluation for you to fill out. Please let us know other topics that you'd like us to cover as we're moving forward.
Yes,
and I do want to alert you.
Sorry, just to add, as we're thinking about planning the next series of seminars, we really value the feedback and the topics that are important to you. So please continue to send those.
Yeah, that's great. So I just want to alert you to two things. One is the next webinar, which is in another month or so on Friday, November 25th. In that seminar, which will be the last one of 2022, Dr. John Semple and I are going to be presenting on surgical prevention of hereditary breast cancer. So Dr. Semple will bring that clinical lens in terms of the options for risk-reducing mastectomy. And I'm going to present some of the latest data on the effectiveness of risk-reducing mastectomy for the prevention of breast cancer, as well as on the survival. So this is some of the first data, and we're excited to have worked on this. And we will be publishing that very soon, but it really is some of the first data on the effectiveness in terms of preventing death in women with a BRCA1 or BRCA2 mutation. I also wanted to let you know that Joanne and I have just finalized the latest newsletter as well, where we present some of the latest research that our group has been doing, with your participation in a lot of this research that we are doing. So stay tuned for that. That should be coming out in the next month or so. So you will have access to that. We'll make sure that we send it to all of you as well. So I just wanted to thank you. Joanne, is there anything you wanted to add?
No, I just wanted to thank Dr. Narod for being here today, and to all of you who participated. And please continue to sign up for our seminar series and let everybody know about the seminar series who might be interested in attending.
Great.
Thank you,
All right.
everybody.
Thank
Thank you so much, and have a nice Friday. Bye-bye.